Welcome to Morning Commute, improving early identification and treatment of hereditary angioedema. In this episode, the importance of early diagnosis and treatment of HAE, Dr. Mark Rydell and Dr. Alina Banerjee discuss hereditary angioedema and its burden for patients. Diagnosing HAE correctly is the first step to managing this disease. What should clinicians have on their radar to distinguish HAE from allergic reactions? Morning Commute is developed by Projects and Knowledge powered by Kaplan and is part of a continuing medical education series. This independent CME CE activity is supported by an educational grant from Ionis Pharmaceuticals Incorporated. Information about the faculty and disclosures can be found at morningcommutepodcast.com/HAE3. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Rydell is a professor of medicine and the clinical director of the Angioedema Center at the University of California, San Diego. Dr. Banerjee is an associate professor of medicine in the Division of Rheumatology, Allergy, and Immunology, and clinical director of Allergy and Clinical Immunology at Harvard Medical School in Boston. I am your host, Candace Hoffman. Dr. Rydell will begin our discussion.
Dr. Banerjee, thank you for joining me again to discuss hereditary angioedema. We're going to focus on early diagnosis and treatment of HAE today. But first, let's talk about the burden this condition has on our patients and the importance of diagnosing it correctly early on. I guess just to level set the conversation, can you tell us a little bit about HAE, sort of what we understand causes it and the symptoms people get?
Thanks, Dr. Rydell, and thanks for inviting me to join you in this conversation today. What we know about hereditary angioedema, or HAE, is that it's a genetic disease, so you're born with it. Individuals with hereditary angioedema are at risk for recurrent episodes of swelling. These episodes often impact daily lives, but when we talk about the actual swelling, it can impact their hands and their feet, which we call peripheral attacks. It can impact their abdomen, stomach, which we call abdominal attacks, and then the upper airway, where it can cause throat swelling or face swelling. And particularly the throat swelling is where it's really life-threatening, and there has been a high mortality when it hasn't been treated. And so maybe I'll go back to you, Dr. Rydell, to talk a little bit about that burden for patients and a little bit about the morbidity and mortality and the impact on their daily lives.
Yeah, absolutely. So as you mentioned, this is a condition that has multiple manifestations, skin, GI tract, airway. And I think we would all appreciate that airway swelling is a serious business, that does have a risk of asphyxiation. And unfortunately, historically, we know there are deaths from HAE. In fact, some studies showing that an untreated airway attack has about a 30 to 40% rate of asphyxiation. So I guess first and foremost, patients and families that are affected by this condition face this fact that they have the potential to die from HAE, and that I think that's a heavy burden that most of us would recognize is a real problem. Beyond that, however, as you mentioned, Alina, the more common attacks are the skin swelling, so hands, feet, face, genital region, really anywhere on the skin, and the abdominal attacks, and these are much more common, but still cause great morbidity, burden, disruption, disability. The truth is no one dies from their hand swelling up, but lots of studies now showing that people cannot work if they have a hand or foot swelling. And these are pretty severe attacks that last for 2, 3, up to 5 to 7 days. So they really are disruptive. People have difficulty functioning when these attacks occur, and they can occur even a couple of times a month in some patients. So it can be very frequent. And then the abdominal attacks, which the pain here is quite severe. In fact, studies have shown, this is a 9 or a 10 on the pain scale, 0 to 10, 10 being most severe. So this is protracted abdominal pain, often with nausea and vomiting, sometimes with diarrhea. And again, very disruptive, not only painful and suffering, but people can't function with this degree of pain, and historically at least have ended up in the hospital for pain medicine before we had more effective ways to manage HAE. So definitely a huge burden. Alina, in your experience, what's different about HAE? Well, there's lots of things that can cause swelling, and as in the field of allergy immunology, of course, we see a lot of allergic type swelling. But what makes HAE different, and why should we think about it differently?
Thanks, Mark. I think certainly recognizing HAE is really important because of the high risk of morbidity, mortality, specifically from laryngeal attacks, and so making the diagnosis. And so, why is it so different? It's different because typically allergic reactions will respond to treatments like antihistamines, glucocorticoids, or steroids, or even epinephrine. In hereditary angioedema, the key mediator is bradykinin, which leads to increase in vascular permeability and the symptoms of swelling due to vascular permeability and fluid leak. And so these treatments that we typically think about for allergic reactions don't work. And so when these individuals are having these episodes of swelling that could mimic allergic reactions, they're not necessarily being recognized or given the right treatment, which can then lead to symptoms for 2 to 5 days. It can lead to unnecessary surgery. We know that patients have had appendectomies or exploratory laparotomies because their diagnosis wasn't recognized, and they're having these severe attacks of abdominal pain, abdominal swelling that aren't being recognized as hereditary angioedema. And so, kind of going back to 101 and thinking about history, if we see someone that is having recurrent episodes of swelling, there's no identifiable food trigger, there's no identifiable medication that we think about that was started in the timing of these swelling episodes, or if there's a family history of somebody that has swelling, because we know that this is a genetic condition. About 75 to 80% of patients will have a family history. Those are the type of things that we have to think about, in addition to the lack of response to antihistamines and steroids and epinephrine, that the diagnosis of hereditary angioedema should be considered. So, Mark, if you're suspecting a diagnosis of hereditary angioedema, how best would you evaluate that patient or lead to diagnosing that patient in your clinic?
Yeah, just to reiterate, an important point is I think thinking about it is the first challenge, right? So I always like to sort of say, not all swelling is allergic, and I think most of us in clinical medicine, that's what we're familiar with. If you see swelling of the face or the lips or the tongue, that's an allergy problem, and a lot of time it will be. But as you just pointed out, there's a whole separate category of swelling that's not allergic, that's mostly bradykinin mediated, and that's this unique mechanism that underlies HAE. So to get back to your question, I think the first thing is to think of it, and there's a couple of clues I think as clinicians we have to ask about. One is, do people that have angioedema, so swelling of the face or the hands or the throat, or even recurrent abdominal pain from angioedema, number one, do they have hives and itching along with that? That's a pretty good clue. If they do have urticaria, or they are really itchy when they get the swelling, that probably is allergic or mast cell mediated. And so we have to recognize that's far more common than HAE. So asking the question about hives is important. People with HAE do not have hives, generally speaking. So the absence of hives, you got to move HAE up to the top of the list. The second is that these attacks often are, as we've already talked about, long in duration compared to allergic symptoms. And so these attacks, this swelling will last generally 2 to 5 days, as you mentioned, whereas allergic angioedema will last maybe a day or two. There's some overlap. It's not a perfect differentiator, but I think asking about the duration of symptoms can be a good clue. You mentioned the family history, which is very important to ask about often, but not always positive in HAE. And then lastly, I think response to therapy. And as we've mentioned a couple of times now, HAE does not respond to allergy medication. So you can treat them with all the antihistamines, all the corticosteroids you want, epinephrine. These people will not get better. And they will tell you that. They have had lots of treatment with those medicines, and I still have swelling for 3, 4, 5 days. So those are the important elements of the history. And those are things I always make sure we ask our patients in the clinic when they present with angioedema. At the end of the day, the important testing is C1 inhibitor testing. So C1 inhibitor level and function, these will generally be low in hereditary angioedema, either the level or the function. And a C4 level can be a nice quick screening test because it will usually be low at all times in patients with HAE due to C1 inhibitor deficiency. So, Elena, that brings us to a little bit of the detail about HAE. There are a few different types of hereditary angioedema, and I don't know if you want to say a few words about how the tests are different in these categories, and I guess do these look any different in terms of the different subtypes of HAE?
No, I think that's a really good topic to make sure that we cover because it really is an important way to think about hereditary angioedema. And you mentioned the basic screening labs or diagnostic labs, which include the C4 level, the C1 inhibitor level, and the C1 inhibitor function. And those labs are really helpful in making the diagnosis of hereditary angioedema, specifically the types hereditary angioedema type 1 and hereditary angioedema type 2. The majority of patients, or about 75 to 80% of patients, have hereditary angioedema type 1, whereas about 20% will have hereditary angioedema type 2. And what's the difference? In terms of lab testing, patients with hereditary angioedema type 1 don't produce the C1 inhibitor protein. And so what happens with their lab tests is that they'll have a low C1 inhibitor level and a low C1 inhibitor function. And so those lab tests are very clear. In hereditary angioedema type 2, which again is the smaller 20% of individuals, these individuals actually produce the C1 inhibitor protein, but that protein doesn't function properly. And so when you look at the labs that we talked about, the C1 inhibitor level is normal, but the C1 inhibitor function is going to be low, which is why it's even more important in those cases of C1 inhibitor deficiency, which is 99.9% of the cases that we're talking about. You have to make sure you look at the C1 inhibitor function, because if you just look at the C1 inhibitor level, you're going to miss individuals that have hereditary angioedema type 2. Now, clinically, they present very similarly. There's really no clinical difference in how individuals with type 1 and type 2 because of the C1 inhibitor deficiency. However, the other group that I haven't mentioned yet, but that I think are important for us to talk about, are a third group, which we term hereditary angioedema with normal labs. So these individuals will have a normal C1 inhibitor level and a normal C1 inhibitor protein. And what we've learned over the last few years, actually very recently, are that there are some mutations that are in the kallikrein kininogen pathway that start around factor 12 and do end up with elevated bradykinin levels, but there's different mutations that have now been identified, most of them in Europe, but about 6 different mutations. And these individuals also have bradykinin-mediated symptoms. In terms of clinical presentation, they do have recurrent episodes of swelling. They don't respond to the typical medications such as antihistamines or glucocorticosteroids or epinephrine. They do respond in some of the cases that we've seen in the case reports to the medicines that target the bradykinin pathway, but certainly a lot more work needs to be done in terms of treatment. Maybe a slight difference in terms of clinical presentation in these individuals in terms of the frequency of tongue swelling being a little bit higher versus the peripheral attacks that we typically see. But I think there's a lot more that we're going to learn as we're doing more genetic testing and understanding how to diagnose these individuals. The biggest challenge, though, is those individuals that have recurrent swelling and normal labs. And so maybe, Mark, I'll ask you to talk a little bit about how you think about that group, but also a misdiagnosis of these individuals where they're given a diagnosis of hereditary angioedema, but that's actually not the correct diagnosis.
Yeah, so it's an excellent point, Alina, and I think the primary issue is, of course, sending the labs that you went over in detail. So you see a patient with angioedema that's recurring, plus minus the family history, but sending the complement studies, the C1 inhibitor level function, C4 level. As you mentioned, we do increasingly think about sending gene panels. There are gene panels for angioedema now that identify at least some of those mutations that you noted in people that have normal complement studies, but still have a story or a clinical history very suspicious for hereditary angioedema. So those are important labs to send. And certainly if you get back normal labs, I would say it's certainly reasonable to consider referring to a center that sees a lot of angioedema. That's always an important consideration. But beyond that, this is a challenge, to your point, that we have a person in front of us who has recurrent angioedema, does not have hives, but has all normal lab studies, including the C1 inhibitor tests, maybe the genetic tests. It's important to recognize that if you look at the data on that group of people, most of them still have a mast cell mediated or angioedema or angioedema due to the allergy pathway, basically. And so we very rigorously encourage people to treat aggressively high-dose antihistamines, sometimes montelukast, sometimes omalizumab, really target the mast cell system, because in 80–85% of people, you will achieve improvement. You will make them better. There is a very small group of people, again, it's probably only 15% of this group that only has recurrent angioedema that have a non-mast cell mediated or probably bradykinin mediated condition. And we put them in this group of HAE normal C1 inhibitor. And as you said, that we don't know the best way to treat them. We think some of the bradykinin targeted drugs are helpful, but that's an area we really need to study more. And so unfortunately, while we have these diagnostic tests, there is some element of trial and error that goes on with targeted therapies and paying very close attention to whether we can prevent or treat these attacks effectively, first with allergy medicines, and then if we need to, if people are still quite symptomatic, refractory to those, then moving to these bradykinin targeted drugs sort of empirically. So Alina, as we kind of move towards the end here a little bit, we've talked about how to recognize HAE in the clinic, or at least the suspicious findings. We've talked a little bit about diagnostic tests, C1 inhibitor studies, genetic gene panels in some instances. We know, however, from numerous studies, and it doesn't matter where you look in the globe, all around the world, there is a delay in diagnosis for hereditary angioedema. And this has consequences because patients, as you said, have surgery, they end up in the hospital, they get treatments that don't work for HAE. If you had to pick a couple of things, why is that? Why do we miss this diagnosis or make the wrong diagnosis so often, leading to these treatment delays?
Yeah, Mark, it's a great question, and I can think of a few reasons why. I think first, it's a rare condition, and so I think that most non-allergists probably have not seen a case of hereditary angioedema, or if they have, it was one and they didn't necessarily recognize it. And so I think there's a lot of learning about rare conditions that is really tough when you don't see them that often. And that really is in counterbalance with the symptoms mimicking an allergic reaction. And so when someone might go to the emergency room and they have swelling, the diagnosis of food allergy or drug allergy or infection or cellulitis or appendicitis kind of tops the list over and over. And so I think that is part of why it's misdiagnosed. I think that we have done a far better job when you look at the literature. Going back a few years, the delay in diagnosis was reported to be about 20 years. And more recent literature suggests that the delay in diagnosis is closer to 8 years, which is still way too long. And I think there's a lot more work to do. But I think it's tough because the condition is so rare. And so I think continuing to educate, continuing to do things around podcasts, because there are easy lab tests. And I think that's the important part of this, that if you think about this condition, then the lab tests to make the diagnosis are actually simple, which is not true of a lot of other conditions. And so because we have the tools to make the diagnosis, trying to think about education around these symptoms, when to think about it and when to do the tests is really going to be important. And so, Mark, I'll bring it back to you to kind of close the loop and highlight a few key points from our discussion this morning.
Yeah, I would just emphasize it is rare, and also these patients see a lot of specialists, right? They'll see their internist or their pediatrician multiple times. They'll see the gastroenterologist. They'll see the pulmonologist or the ENT because they're having airway or respiratory symptoms. They see the emergency department a lot often, right? Or the hospitalist during their admissions. And unfortunately, in our sort of specialized era of medicine now, everyone looks at symptoms through their own lens. So I think HAE is mistaken for lots of other problems, GI problems, gynecologic issues, dermatologic conditions, allergic reactions, you name it. People sort of get misdiagnosed with various things. And so I think that's part of why we talk about it, because you sort of have to look at the broad view and through a lens of the entire patient journey to try to piece together, they're having abdominal pain and facial swelling, and sometimes they suddenly have respiratory issues. That sounds like HAE. And then, of course, sending the labs or getting them to the right specialist. So I think this is an area where we can continue to improve. And most of this is just thinking of it, knowing that these are the symptoms. Let's do the appropriate testing. And as we kind of wrap up, I'll just bring it back to the patients. The most important thing here is that we get the right diagnosis, the right treatment to the right patient. And these are patients and families that really do suffer, as we've just talked about, for years. They suffer from disability. They suffer from a fear of dying from this. And they suffer from an unpredictable condition. We didn't talk too much about it, but most of these attacks happen for no rhyme or reason. They just come out of the blue. And that's a very difficult way to live. It's led to, in some cases, anxiety and depression because of the unpredictability of this dangerous condition. So at any rate, I hope that we've presented some interesting and important data. Keep HAE in your mind as you see patients. Remember, there are blood tests, C1 inhibitor tests, levels, and function that can either make or exclude the diagnosis in most cases. And we're still learning about a subset of patients that may be identified best through genetic testing. As we know, genetics is making its way into pretty much every arena of medicine, and that's certainly true here. So Alina, thank you. As always, it was interesting, it was fun, and I hope that it was informative for you out there listening. Thanks for being a part of this.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/HAE3. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.